Perfect. All right. Good afternoon, everybody. Again, my name is Lindsay Zimmerman, and I will be your host today. Please message Kimber, and she's in the chat if you have any technical issues. And also, please feel free to drop your name in the chat along with your affiliation and if this is your first echo session. So today's session is going to include a discussion on treating pediatric hepatitis C in primary care by Dr. Alfaro Cruz. And we will have case presentations and Q&A sessions. Sorry, folks, I'm having technical difficulties today. As always, you can scan the QR code or you can use the direct link to register for the continuing education credit. That is a requirement in order for you to get your certificate. So just ensure that you do register for today's session. Just a few introductions and announcements before we get started, and just a few reminders as well. We've already kind of covered this, but if you didn't hear me, if you're just now joining, again, just introduce yourself in the chat, affiliation, role, and if this is your first echo session. And I will go ahead and turn it over to you, Dr. Alfaro Cruz.
Hi, good afternoon, everyone, and happy Thanksgiving as we are preparing for the next month of holidays. I am Dr. Alfaro Cruz. I'm a pediatric gastroenterology, hepatologist, and nutrition in East Tennessee State University. And today we're going to talk about treating pediatric Hep C in primary care settings. Next slide, please. I have no financial disclosures or conflicts of interest to report. Next slide, please. So let's start by just kind of, as the new guidelines it came into medicine so we can start practicing. We know that we can actually do early screening starting right at 2 months of age. But now that we have new medication or direct acting antivirals, we can actually start treatment as soon as they turn 3 years of age. Now, why is this important? Because we don't have to wait now 5, 10, or 15 years in order to treat. Once you have a confirmed Hep C, and that kid has turned 3 years of age, then we know we can start treatment right away. Next slide, please. So what do we need before treatment? So this is very important because what we want to do is, as the screening process has been very simplified, we're also trying to simplify what do we need to treat and what do we need or what kind of medications we need to treat in order for us to start moving from waiting a subspecialty appointment to get treatment to actually get those patients treated as soon as possible in the primary care setting. Now, usually when we talk about what do we need before treatment, right? You are going to get a lot of labs. You're going to get a CBC, you're going to get ALT, AST, that is going to help you kind of calculate the fibrosis 4 index, the CTP score, and that will help you kind of do a cirrhosis assessment. Now, it's important to know that we don't need a liver biopsy in order to decide whether that patient needs to be treated or not. That you need to know what kind of medications that patient is taking beforehand, because that will kind of help us know if there can be any concerns about interactions once we start treatment with one of the direct acting antivirals. And the goal is to kind of assess for those potential drug-drug interactions in case the patient is taking medications like steroids, PPIs, or even if they're taking ADHD medication. Also, we need to know that we are going to have to provide education to the patient and the family about taking the medication, how to administer the medication, the importance of adherence to the medication, and talking about prevention as well as the possibility of reinfection. We always talk to our parents about this is a cure, but that does not mean that you're going to be cured forever, meaning in the sense that you can actually get reinfected. So that's something that we always want to make special emphasis because we don't want, especially as kids are getting older, become teenagers, and starts having either getting into relationships where they're going to have sexual intercourse, or sometimes they can start using drugs or IV drug use. We want them to know that by the fact that they were treated doesn't mean that they cannot get reinfected. So education to the patient and to the family is going to be very important right before starting treatment. Next slide, please. So, what are the tests that we require before treatment? So, as we were saying, we are going to get all these the CPT score, we're going to get the fibrosis index score, but we are going to need to get a CBC, a hepatic function panel, and that will include your ALT, your AST, your direct bilirubin, your albumin, and your total bilirubin. We are going to get an INR level. We are, and this is actually applied more for adults about regarding the glomerular filtration rate, which we don't use it as much in children, but it's something that we always get it when we get a complete metabolic panel. You are going to get a Hep C viral load. And this is kind of important because remember, before you turn 3, there is still kind of the idea that there can be spontaneous resolution. So by the time that patient has turned 3 years of age, we want to get a Hep C viral load because this is actually going to help us see if there is any active virus at that time. And that's the patient that you're going to treat. You are going to get an HIV antigen antibody test, and you're going to get a Hep B surface antigen. By as our new medications usually will treat all genotypes available, but for insurance purposes, you are going to have to get a genotype. And so as time progresses, this may actually be something that will change. But as for now, we want to make sure in the labs that you get a genotype. Again, I want to make special emphasis that a liver biopsy is not required in order for you to start treatment. And that's kind of a way to make it simple, to make it accessible so we can actually get treatment as soon as possible and not depend of waiting times or getting to see a specialty as well. Next slide, please. So these are going to be 5 of the evaluation factors for treatment. And as you have mentioned, and I'm kind of repeating it, but it's going to be important. So you're going to get your lab results, and that's going to include your Hep C viral load, which you use the Hep C PCR RNA to get that load. You're going to get a genotype that this is more for insurance purposes, as well as going to help us decide which medication the patient can get. 2 of the new medications that we have are polygenotype. They will treat all the genotypes available. 1 of the medications will not treat 2 of the genotypes. So this is going to be important to know. Hep B serologies, and then the goal of obtaining liver enzymes or to kind of assess for any potential liver damaging. It's going to be important to know the patient demographics, the age and the weight, because a lot of especially in kids who are younger, when we start, it's going to be depending about the weight that that patient has. Drug interactions. Most commonly, or most of our children, usually, if they are on any medication, it'll probably be for heartburn medications, for seizure medications. Some patients may be on ADHD medications. Also, we need to figure out if they are on any HIV medications or anticoagulants as well. There's going to be an insurance formulary, and I don't know if we can put it on the chat because usually that's something that you can find on the Tennessee Department of Health. One of the forms that we'll need to fill out in order to get approved of this medication. And then we're going to talk about the patient's preference. As they get older, they do have preference regarding whether they can actually swallow pills or they would prefer to have the pellets done. Also, it will be a preference regarding how long they want to be on the course of medication. As the weeks can change between. And also, we're going to have to see what the insurance tool will actually, or what's the preferred medication that that insurance will pay for. So those are factors that you have to consider when we're talking about starting treatment for Hep C. Next slide, please. So we have right now available for children 3 different types of drugs. And as you can see here, for example, we have like a combination of like capavir, prevenstivir that will work for any genotype, and the duration of treatment will start at 8 weeks. And that's actually talking about patients who have never been treated before, who have not failed any medications, who are treatment naive. We also have a combination of sofosbuvir, velpatasvir, and that will also work with any genotype, which is 12 weeks duration of treatment. And then we're going to have a combination of lenacapavir and sofosbuvir for children with genotype 1, 4, 5, or 6. And these will have a duration of 12 weeks. Next slide, please. So let's start talking about each one of them. And so this is kind of gives you an idea. When we talked about we need to know the demographics of the patient, we need to know about their age and their weight. So let's start with glycapavir and prevensivir. Its brand name it's Maverick, and we use it usually with an 8 weeks duration. You're going to see here that depending on the weight of the patient, the dose of the medication will change. We have from less than 20 kilograms, and you can see an initial dose of 150 milligrams. And once they are more than 45 kilograms and greater than 12 years of age, the dose usually it's higher, about 300 milligrams a day. These are a way to simplify how we're going to have to give the medication and what dose of the medication can be used as well. As you can see here, you can find these data or these tables at the end of syndemic, tennessee.org dash echo. And that's going to be a good way to actually get some of this information about doses just to simplify where you can find it. Next slide, please. As for glycapavir and prevensivir, we do have a combination. We already talked about it, that it's a pangenotypic from genotypes 1 to 6. We have presentations where it comes in oral pellets, especially for those 3 years old and above that can still not swallow tablets or pills. And usually you'll have a package that has 50 milligrams per packet. You can actually mix this with soft food that sticks to a spoon. It can be peanut butter, it can be jam, Greek yogurt, anything, or even applesauce, anything that you'll feel that the kid will actually make it easy for that kid to swallow it. We do recommend and we tell the parents do not let them chew the pellets. Common side effects of these medications that we can see can be headaches and fatigue, especially with the first doses. But usually, as they start taking the medication over a couple of weeks, then those side effects tend to actually decrease. We have talked about if we can give this through a G tube in case the patient has a G tube, and yes, you can. We had even talked about that fact that you can actually crush some of the tablets and just mix it and give it through the G tube, if that is also one of the concerns about special patient populations. Next slide, please. The second option of medication that we have is sofosbuvir and velpatasvir. Brand name for this is Epclusa. Usually the duration of treatment is going to be 12 weeks. And as you can see here, again, you can log in onto the website of Endosendemic. And we also have options depending on the weight, where less than 17 kilograms is going to be 150 milligrams, and more than 30 kilograms is going to be a 400 milligram dose. Now, next slide, please. This is also a pan-genotypic medication, meaning that it will treat genotypes 1 to 6. We do have the advantage that it comes in oral pellets as well, and it can be mixed with or without food. Now, I've had some patients who complains about the taste of the pellets, and so those are the ones that I usually tend to recommend just mix it with the food. Again, some of those kids may actually be chewing on the pellets as well, and so we kind of explain them the importance of just swallow the pellets or mix it with food and then swallow that spoon of food. Common side effects we can see with this medication, and usually, again, considered normal within the first couple of weeks. Headaches, some nausea, some patients complain about vomiting or feeling very nauseous, or some heartburn, and then fatigue can be some of the side effects. This is another medication that the treatment will be a little bit longer for 12 weeks, and it will depend whether the insurance prefers sofosbuvir, velpatasvir, or Epclusa versus Maverick as well. Next slide, please. The third option that we have available for any kid who is 3 or above this age is lenacapavir sofosbuvir, and the brand name for this is Harmony. The duration of this treatment is going to be 12 weeks. And again, you can see how it uses the same body weight as Epclusa with less than 17 kilograms. The dose change, and it's about 33.75 or 150 milligrams. And then more than 35 kilograms, we're talking about 400 milligrams per day as well. Next slide, please. This one, I kind of want you to remember, Harmony or lenacapavir or sofosbuvir is only going to be for Hep C genotypes 1, 4, 5, and 6. What is important to know about our region is that the most common genotype is 1. So most of these drugs or all these drugs are actually going to be able to treat a Hep C. It comes in oral pellets. It also comes in pills. But the oral pellets, again, have the advantage that they can be mixed with or without food. Same issues. We don't want them to chew on the pellets. The side effects are very similar among the three of them. Headaches, GI issues, and fatigue. Usually when patients are taking Harmony, one of the main concerns that I hear is that the first couple of doses usually tends to cause a little bit of nausea or reflux, which is kind of one of the side effects that we have seen with this kind of medications. Next slide, please. So once we have started treatment, once we have gone through the process of getting a PA for these medications, fill out all the forms, and you have decided which one of these medications the patient will start, then we talked about monitoring for the treatment, right? Or what are we going to monitor during therapy? Now, if it's a patient that you feel you trust the family, you trust the patient, you know they're going to be compliant with the medication, they have the motivation to make sure Hep C is eliminated, then usually I recommend checking with the family at least once or twice. It can either be done via telehealth or via phone call, just to kind of say, hey, how things are going. Are we having any side effects? Have you had any issues taking the medication? In order to kind of assess how things are going. A lot of the times, we're going to bring them into clinic, and usually at week 4 after they have start treatment, we most of the time are getting a CBC, a creatinine, and liver enzymes and total bilirubin to make sure that nothing is actually trending up or they're not having decreasing their white blood cell count or hemoglobin count. Now, if you are concerned about adherence, or this is a patient who has actually failed treatments in the past, or you feel that, especially kids in foster care that are being moved from one house to another, and sometimes doses can be missed or skipped, then you can consider getting a Hep C PCR RNA. Kind of see where we are. Technically, at the 4th week mark, we should have an undetectable or at least a significant decrease of the viral load in the blood. So this can actually kind of help you guide and provide counseling to the families regarding the importance of being compliant. Now, usually, at the end of the treatment, we don't do any testing, except in those cases where, again, compliance or it has been patients who have already failed previous treatment lines. That's where you can obtain a Hep C PCR RNA. But what I want you to kind of get out of these conversation, this talk, is that we do want to check 12 weeks after you have finished treatment, in all patients that were treated, another Hep C PCR RNA to make sure that there is no detectable viral load in the blood, meaning that they actually have been cured from Hep C. So if you ask me, Dr. Alfaro Cruz, what's the test that we really need to do if we have a patient that lives 3 or 4 hours away and they cannot come all the time, but we can get this, then yes, at 12-week marks, when you have end treatment, we want to get that Hep C PCR RNA to make sure they have eradicated the virus. Next slide, please. So what's the therapy goal, right? Pretty much we know we want to eradicate that Hep C RNA, and what we mean by that is that it's predicted by the attainment of sustained virological response, this defined as undetectable RNA level 12 weeks following the completion of therapy. And that's where I want to show you this next graph. Next slide, please, where it kind of shows you and what we were talking, right? We expect that between those 12 weeks after you have finished the treatment, we still have an undetectable viral load. Now, remember, in the cases of Epclusa or Harvoni, you are going to check at the 24-week mark. But in the case of Mavyret, which usually the treatment course is only 8 weeks, you are going to check at the 20-week mark, which will make 12 weeks after ending treatment. Now, remember when I told you that if you are concerned about a patient not being compliant with the medication, or a patient who has, this is his second treatment, then yes, if you want to get at the end of treatment or at the 4-week mark, you can do it. And we would expect, according to this graph here, that we would find undetectable levels. And that will be kind of a good prognosis that he's responding to this medication as well. Next slide, please. So we talked about counseling. So when we talk, these are appointments that we talked about the treatment, we talk about the side effects, we talk about how we're going to monitor that patient, but it's also important during those appointments to provide counseling, because you want to explain them three things actually. One, that reinfection is possible, that even if he gets cured, there are certain behaviors, unprotected sex or use of IV drugs, that can actually lead to get reinfected with Hep C. That treatment does not prevent reinfection. And I know in the adult world, they tend to do it more, but we have to provide this counseling, especially to adolescents, to try to explain them that treatment does not prevent reinfection, and that their Hep C antibody will always be positive no matter what. So in that case, where a patient has already received treatment for Hep C, you're going to need to get a Hep C RNA PCR as the test of choice for all future testing, if you are considering that that patient may have been reinfected with Hep C. Next slide, please. I guess that was it. Any questions before we move on to the cases?